Okay, so I think we should get going. So welcome everybody to the March edition of the CMR Journal Club. I'm welcoming you from snowy Montreal. I'm Matthias Friedrich, and today is a special day because today it's the first time that we present a featured paper. So instead of presenting two papers with 15 minutes each, where we have typically a 5 to 10 minute presentation and then discussion, this time we take more time. So this format will be used occasionally in the future for papers with a potentially very high impact on either the clinical application of cardiac MR and also on decision-making or any other really groundbreaking impact this paper may have. And today I'm very happy to welcome Pankaj Garg from the University of Sheffield in the UK to present a paper on how CMR may be able to assess left ventricular filling pressures. The paper was published in the European Heart Journal and was also accompanied by an excellent editorial by Davide Genovese from the University of Padova, who's also joining. Welcome, David. Nice seeing you.
Hi.
Also welcome to David Blumke, who I just joined. So the paper today, I think, is of an extraordinary relevance because, as Pankaj already briefly mentioned, CMR, as any other imaging techniques, has its challenges with measuring pressure. On the other hand, hemodynamics and pressure are very important for clinical decision-making, especially in heart failure. One problem I'm often seeing as a cardiologist in clinical settings is that people do not necessarily differentiate well between congestive heart failure and forward or low output heart failure. And in that setting, pressures, so LV filling pressures or pulmonary wedge pressures, for that matter, as a surrogate marker, may be extremely important. If we think of disease like HFpEF, so heart failure with preserved ejection fraction, it is very important to understand how this affects hemodynamics. So the tissue component is one thing, but the hemodynamics and function is another one. So in that context, I'm very, very excited. I'm looking forward to the presentation of Pankaj in the paper, and then have a comment maybe from Davide, and then everybody who has a question, feel free to post it in the chat or just to unmute and speak up. Let's have a lively discussion on this topic, which certainly is not easy, but certainly extremely interesting. Pankaj, take it from here.
Thanks, Matthias. Thanks for inviting me and considering this as a feature paper. As you rightly pointed out, the hallmark of pathophysiology in heart failure, the unifying hallmark is rise in intracardiac pressure. And that's the definition both by the all the major boards in US and in the European Union. So, and in particular for the left heart, rise in left ventricular filling pressure dictates symptoms, mainly shortness of breath, and thereafter the whole sequelae of heart failure. And it doesn't depend necessarily on the stroke volume or the ejection fraction. Is the rise in the pressure which dictates, and you can have a patient with advanced heart failure with dilated cardiomyopathy, but with preserved with preserved LV filling pressure and normal filling pressure. And you can have a patient with preserved ejection fraction, but with a very high filling pressure. So filling pressure is the hallmark behind heart failure, and that's very important. Historically, I would like to go back beyond this paper historically. How would we do this 50 years ago? We would have to actually cross the aortic valve to measure the left ventricular end diastolic pressure or the LV pressure trace. We've moved on since then. In the last 50 years, we've built a lot of database. We published a meta-analysis of all the echo studies which have looked at the left ventricular filling pressure, roughly around 27 till 2021 studies with a mean recruitment range of roughly 100 to 20 at max, to be honest, not mean. So the maximum recruitment was roughly around that in those 27 studies. The overall association with multiple echo metrics for left ventricular filling pressure, mainly measured by the wedge pressure as a surrogate marker, as you defined, was roughly around 0.6. Some of those studies were done in ITU patients, who are not ideal heart failure patients. And more lately, we were seeing refinement in echo studies. An LV filling pressure assessment till date by echocardiography remains one of the most difficult tasks. We take into account several parameters of LV mitral inflow and TDI measurements, including E prime and A prime. And then we take into account right heart metrics, including TR peak velocity assessment. And my argument is, if your TR velocity is greater than 2.8 meter per second, by that time you've already adversely remodeled your left atrium, the whole pulmonary vascular bed, and then you're looking at the TR. So you're taking into account really very serious patients, not detecting early disease at all. So, but you can argue either way, and that's where we needed some sort of, at the minute, if you look at the guidelines, it's if you have an equivocal echocardiography, resting transthoracic echocardiography, you move on to stress testing. And sometimes in these elderly cohort, that's not the ideal method. Or invasive assessment still plays an important role in ESC guidelines. So we do need some sort of complementary resting, non-invasive method, which can help us to diagnose raised LV filling pressure. And that was the motive behind this paper. And I think that's important to get that message across. I'm sorry for taking that long to explain the motive behind this paper. It was to provide a complementary assessment by, to echocardiography, which is a bench, which is the first line test to assist in diagnosing raised LV filling pressure. The strengths of CMR you already mentioned are its precision for volumetric assessment. We know by different vendors, whether you go on Siemens scanner, whether you go on GE system, the volumetric assessment by balanced SSFP cine acquisition, by drawing contours, endocardial contours inside the left atrium or inside the left ventricle, the inter or intra-observer variability remains very low. And using those fundamental metrics was the aim to develop some sort of filling pressure model, a physiological filling pressure model in this study. In this study, we recruited 708 patients in Sheffield in the derivation cohort. And why Sheffield? Sheffield is one of the largest pulmonary hypertension centers in the world. Uniquely, is one of the only few centers in the world which does right heart and CMR on the same day. So that gives a unique kind of set of data set, which was very relevant for this study. However, in this study, we kind of filtered out all the right heart causes of PH. We looked at only the left heart disease patients so that the model can be applied more generically into the heart failure patient population who are short of breath and who present with raised LV filling pressures. In 708 patients, all we did this is using very simple metrics in cardiac MR, which I will go on to in the next few pages, if I can. We used simple volumetric assessment both for the left and right heart, including left atrial volume assessment. This was intentionally done because we knew left atrium is associated with preloading conditions on the left ventricle. So that's why taking into account left atrial maximum volume was important. And we looked at its association with the invasive wedge pressure in 708 patients who had same-day right heart and cardiac MRI. The cardiac MRI protocol historically in Sheffield was very basic. I have to be honest about it and very transparent. it was mainly involving cines, a baseline cines, with both for left and right heart, and with minimal tissue characterization. And this is why you don't see much talk about tissue characterization in this paper, and that's where possibly future papers should address that in LV filling pressure modeling. There was very little the flow data, a consistent flow data available for all that, for all the cohort, and that's why we didn't include flow data in this paper in developing one of the foundation models for LV filling pressure. We recruited 127 patients, 15% of patients, prospectively again outside the study, who had same-day transthoracic echocardiography, as well as CMR, to validate the model we developed in the derivation cohort. So looking at all the association parameters, which came out associated with the wedge pressure, LA volume was demonstrated the highest association. Now I'm going into results section. And if I remember rightly, I think it's somewhere. Yes. So the association was roughly 0.55 for left atrial volume, and left ventricular volumes had a bit, modest association, and left ventricular mass was at 0.28, again with a very significant p-value. And we tried to derive a linear model using several methods, to be honest, in regression modeling, including offline, I think, using even machine learning models, but we realized nothing came out better than the linear regression, which was using left atrial volume and left ventricular mass. And when I saw that, I was very happy with that model. And to explain that model more precisely, left atrial volume is actually a marker of preloading conditions on the ventricle. So, and left ventricular mass, on the contrary, is a marker of afterloading conditions on the ventricle. And between those two, they are kind of informing us about the left ventricular filling pressure, if that makes sense. Most importantly, one would argue left ventricular mass is playing the role of HbA1c as a marker of filling pressure. So it's not informing you about LV filling pressure today, it's informing you about LV filling pressure for last few months. And that's where I think it has a prognostic impact. Left atrial volume, on the contrary, actually can go down acutely or go up acutely depending on the preloading conditions. So that is bringing in the acute changes in left atrial volume, or the acute changes in LV filling pressure into the model. And between those two, they make a big physiological sense. And if you currently read the ESC guidelines document, when we talk about left ventricular diastolic impairment, those are the two most important prognostic markers: left ventricular hypertrophy and left atrial volume. And that's where this makes a very good physiological sense. So, and then we tested the model in a validation cohort in 127 patients, where we noted the association of the model was as good as here in ROC curves. You can see we demonstrated it worked quite nicely with an area under the curve of 0.81 for picking up wedge greater than 15 millimeters of mercury or equal to 15 millimeters of mercury. We had transthoracic data for these patients. Again, an integrated approach of transthoracic where you look at the EOE prime, EA ratio, and TR peak velocity, and integrate it to make a diagnosis of either it's normal LV filling pressure, whether it's in the indeterminate category, or whether it's high filling pressure. we realized that when we looked at the whole data set, we were able to reclassify those patients who were wrongly classified or went into the indeterminate category into the right category when we were using CMR derived LV filling pressure in roughly around 71% of patient population. So again, providing complementary role there. Echo is a very versatile diagnostic modality. You can do it at bedside. You can't do CMR at bedside. And therefore, it is kind of a adjunct imaging modality to help facilitate diagnostic strategies. This is where we thought about it. And that's the hallmark of this study, actually. And I think this was suggested by the editorial team as well to come up with a proposed decision-making algorithm which will help us, where the CMR is already being used to subphenotype patients in heart failure. We know that for a fact, whether it's HFpEF or whether it's HFrEF or HFmEF. We're using CMR to subphenotype the etiology in patients with heart failure. But now it can also help us decide on LV filling pressure, and that's where it can supplement that diagnostic strategy. And even if CMR doesn't help, then we still have further imaging modalities, including stress echocardiography or invasive hemodynamic assessment to assist the diagnostic strategy in patients with suspected heart failure. Is CMR-informed wedge pressure as good as invasive wedge pressure for prognostication? That was a very important question. And luckily, we had strong data of outcome all-cause mortality in this patient population. And we demonstrated that invasive and CMR, there was no difference for predicting outcomes. And that power remained nicely even in patients who were separately recruited in the validation cohort. So again, demonstrating its power for not only informing the wedge pressure, but as a composite endpoint in predicting all-cause mortality. I think this is all, if this paper solved everything in LV filling pressure, then my career would have ended today. This is just only the start. This sets the scene for future cardiac MR hemodynamic assessment in the right heart, in the left heart, and further iterative development using very similar techniques in echocardiography, like left atrial strain, which I'm sure David would like to mention, and more physiological parameters from CMR, including flow parameters and further assessment into those models and develop those models into more precise models. But this kind of gives us the foundation to start working using CMR for informing LV filling pressure. With that, I would like to wind up. Thank you.
Thank you very much for the fantastic and lively presentation of your paper. And I absolutely share your enthusiasm about the opportunity to eventually get also into the hemodynamics with the CMR scan that is already extremely versatile, more comprehensive than any other imaging modality, and provides similar information, quantitative information on function, volumes, and mass, and then using these parameters then to also estimate others. It's not a measurement, but the estimation, that's fantastic. Now, Davide, you wrote an editorial also in the same issue of the European Heart Journal on that. So you are also in the research about the hemodynamics, and you saw some, let's say, still some limitations, and you mentioned arguments about the question whether this could be defined as a model with a sufficient diagnostic accuracy. And so, of course, it would be very interesting to hear from you what your thoughts are, and then we'll get to questions from the audience.
Okay, thank you. I will first start by, I want sincerely to compliment with Professor Garg for his work. We got really excited in Padua when this paper came out, because you know, it's something. The main point I think of this paper is the fact that it finally challenged the paradigm that we have, that CMR cannot be used for feeling pressure evaluation, and I believe this paper will be the landmark for all the future research that will be done on this topic. It is because we got really excited in Padua that we wanted to apply this this model in our clinical practice, and for doing that we really went deep into the results of the paper, and what we believe is that some consideration has to be made before the widespread use of this model in clinical practice. The first, could I share my screen?
I think, Pankaj, you may have to unshare your screen. Yeah, exactly, and then.
If I can. I mean, it's really. Can you see? Okay. Can you see this?
Yeah, it's coming up.
Okay,
but it's not on, okay. At least not for me. It's now we're there.
Right, now, okay. I mean, it's really short. It's just 3 points that we made. The first thing is that from a clinical perspective, despite this model has a very high specificity of 92%, the sensitivity of this model was 39%, which is low. So for a clinical point of view, it means that every 10 patients with dyspnea referred to having a CMR, this model unfortunately will misclassify as normal feeling pressure 6 out of 10 patients. So this is something that has to be taken into account. The second thing is the fact that despite there's no systematic bias in the Bland-Altman analysis between the CMR model and the invasive measurements, the agreement and the interchangeability between the two methods has to be defined by a clinical judgment of the limits of agreement of the Bland-Altman analysis. And unfortunately, the limits of agreement in this case were quite large, because the limits of agreement ranges from -10 to +10 millimeters of mercury. So definitely, this is this model can provide insight, useful insight into the wedge pressure assessment, but probably it cannot be so accurate that it could be used interchangeably instead of the wedge pressure evaluation, because in the worst case scenario, you might have also misleading results. The last thing is I'll start by saying that I'm mainly an echocardiographer too, and we found that the value for the performance of the diastolic dysfunction algorithm was in the population study, it was very low, like 25% of accuracy. I mean, we know that the diastolic dysfunction algorithm has a lot of drawbacks, a lot of limits, and we know that the accuracy is suboptimal. Like we know that it may range in reduced ejection fraction to its best performance around 80–85% to the preserved ejection fraction group, where it can be as low as 60%. But still, 25% is very different from 60%. And the fear is that from a practical point of view, if you we have to remember that if you have a population with a disease prevalence of 50%, and you just choose by chance if the patient has or not the disease, you will get 50% accuracy. So that's why every diagnostic test is based on the fact that it has to be an accuracy that is significantly higher than 50%. That is the line of basically chance. And so despite this point, I will conclude by saying that this work is really huge for its potential clinical implication. That I believe the main thing that will add to the research community is at first a very large landmark paper from which we have to start, and to think that actually this paradigm of the limits of CMR for the wedge pressure evaluation has to be challenged and has to be studied, and we have to discover some and we have to improve this model. I believe this could be probably done by the use of some functional parameters that we have also in CMR. I'm not referring to flow parameters, but I'm referring to, for example, left ventricular strain or left atrial reservoir parameters as LA strain. Since also this change, this attention to this new type of parameters is what we have also seen in the field of echocardiography in the last 5 years or so. So I believe we're going in that direction.
Thank you, Davide. Thank you very much. So, Pankaj, any direct comments, answers?
Sure. No,
especially on these 2 points. I think the first was the sensitivity specificity relationship. If you have 90% specificity, people may think, okay, why don't you sacrifice some of that to increase your sensitivity? And then the second one with the model itself and the systemic bias and the limits of agreement. So maybe these 2 points.
So, I mean, this is a very large study, and we're recruiting roughly around 708 patients, very heterogeneous patient population. And even though one could argue this is a negative aspect, but it's also a positive aspect, it gives a framework. The low sensitivity argument, I would say, this is where I started off saying that actually you're not at the minute going to use CMR completely independently. It's used as an adjunct to an echocardiography assessment. And at the end of the day, it's a full clinical assessment. And I can tell you today where this equation will not work. I know for a fact where this equation will not work. And I think that's something also as an academic cardiologist, we need to know, or as clinical cardiologists, we need to know where this equation is not going to work. So for example, in an athlete's heart, this is not applicable at all. You've got a dilated left atrial volume and you've got increased left ventricular mass, both in a positive remodeling aspect, not in a negative remodeling. And we're looking here at heart failure patients where this is resulting in negative remodeling. So there are several disease processes where this will not work. But it is making some physiological sense. And the argument is prognostically relevant. One thing I would like to mention is actually independent of this cohort, we will be seeing data coming out from the UK Biobank using the wedge pressure model. Quite game changer data, actually looking at hospitalization. There are other data sets from other centers I'm aware in Italy and other places which are using this model to demonstrate prognostic significance of this model in their patient population. So this gives us a starting point in the CMR community to actually build some evidence in LV filling pressure model. This is by no means the perfect filling pressure model.
Okay, thank you. So we have a few questions from the audience or comments. So I'll start from the beginning. So Venkatesh Murthy, I don't know whether you want to speak up yourself or unmute yourself, and otherwise I'm happy to read the question. So he says, really nice study, an interesting population. Would you expect your predicted PCWP to be dynamic? Are you responsive to impact of medical optimization and volume status?
So I think I briefly mentioned this, that there are two parameters here. One is more reflective of sort of 3 to 4 months after loading conditions on the ventricle. So it's not a dynamic parameter, which is a left ventricular mass. LA volume is probably a more acute marker of LV filling pressure. And we have a study coming out demonstrating that in patients who've had stress perfusion CMR. We've done a stress left atrial volume assessment, demonstrating how LA volume increases in size. But I suspect going forward, to be honest, we will need more dynamic markers into the model, which reflect instant pressure. And for that, even though I know what Davide is saying, I do think there will be an importance of flow, which guides relative pressure, intracardiac pressure, to estimate LV filling pressure. And I do think, like echocardiography, CMR will need to think about it.
Okay, thank you. Next one from Fahime Ganbari. Great talk. Did you consider left atrial volume measured only in 4-chamber view or biplanar?
That's a very good question. We considered the LA volume in biplanar method using the 4 and the 2-chamber views, but we have data supporting that you could only use 4-chamber left atrial area as well. And we are looking into how we can bring that out into the public domain, mainly because you can argue sometimes when you're in a busy clinic, you just go whoop, and you want a quick data to generate your outcome. So we are looking at that, but yes, it is biplanar method in this.
Then also a question regarding the methods. Have CMR studies been interpreted by one observer?
The CMR studies were blindedly analyzed by our radiographers, a team of radiographers, not by cardiologists, who were trained over several years to do CMR post-processing.
Yeah, okay, thank you. And then another one also from Veg Murthy. The survival curves in figure 2 don't start at 100% in some cases. Could you explain?
I think that might be just how they were drawn, to be honest. I think we probably, I'm just trying to...
So, yeah. So you're not aware of any study design or observations that would explain that? It's a bit more graphical thing.
No, it's more of a graphical thing, I think.
Yeah. Okay, so then let's go to the next one. Thank you for the great presentation. Do you think it is more accurate than using left atrial transit time by CMR to evaluate left ventricular filling pressure? So comparison to left atrial transit time.
Well, that's a tricky one. The real answer is, to be honest, I don't know. I think left atrial transit time is a very important marker. Having said that, because it's a true marker of LV filling pressure.
Yeah, yeah. I mean, I have to interject also the comment. Sometimes, especially in the CMR world, because the CMR often provides innovative ways to see things. So very often it happens that the marker that we want to then compare doesn't have a really good gold standard. So that's also a problem here, because the gold standard, as you mentioned initially, is not necessarily perfect and has been acquired sometimes a long time ago in a small number of people with methods that today may not stand the judging of time. So in this case as well, one might argue, okay, you try to use the end diastolic filling pressure, and even this is a marker that we can measure actually in the cath lab. Do we really know that it's the best for the patient in terms of decision-making and prediction? So it may be that a marker that even does not correlate extremely well with that marker be the better marker in the end. So this
exactly. That's a very good argument you're making. And I was actually going to end my kind of argument.
I'm sorry, I didn't know.
But let me explain to you. I mean, I do work in invasive labs as well. I do pressure volume loop now. Using CD Lycom at Norwich. So we do that in HFpEF cases as part of research study. And we're beginning to realize, I mean, we all know who've been in the invasive labs that there's so many markers your LV filling pressure is dependent on, especially the wedge. But if you go inside the LV with a pigtail catheter, whether your catheter is filled with normal saline, which will result in damping effects, because it's got lesser oncotic pressure than the blood pool, whether your catheter is filled with contrast agent, which will result in smoothing of the end diastolic curves, and you'll probably get better LVEDP, and where the pigtail catheter is positioned, apex or outflow tract or mid-ventricle or bent towards the mitral annulus, there's so many factors. We have not, and if you go and in last 50 years, we've talked about this non-invasively, but if you look at the invasive side, our invasive colleagues have not defined how this should be done to perfection in the invasive lab. And that's where the problem is. And we do need markers which actually inform prognosis, are very reproducible, and kind of hint to the LV filling pressure. And that's where this kind of
I absolutely agree. Remembering my time as an invasive cardiologist, over time, it was more that I lost confidence than I gained confidence in what I was doing actually in the results. It's also when you look how people are actually performing the measurements in real life. Sometimes the data are not good, and then they take a guess. Okay, I take this one here, and so it's really up to the experience and to. So that's why I also think, in the end, probably it may be necessary to, and you kind of alluded to that already, to combine not just marker 1, 2, 3 in an equation. I think that's a great starting point, but machine learning may give us now options to digest lots of markers and then create a kind of a hemodynamic signature that would then inform, and I would slightly differ with what you said, because it said we need prognosis, I agree. But to me, the real key target is to inform clinical decision-making for better outcomes. So eventually we will have to show that the use of such a marker in clinical routine improves outcomes. Regardless of whether it's accurate, regardless of whether it has a prognostic value, regardless how beautiful the images are, the use of this marker has to eventually be good for improving outcomes. So we have more questions. There is one here from Thomas Zaremba. Can one expect this model to work in LV remodeling during pregnancy, which is also kind of a high volume, high cardiac output state?
One could argue it can inform a relative change in filling pressure during pregnancy. But remember, this model has not been developed in pregnant females. And I would be very cautious in using this model in very young patient population, because you could have athletic remodeling in that patient cohort. Especially, in pregnancy, this has not been tested, but you could argue you could use it to monitor relative drops and changes in pressure gradient.
Yeah, and along that line, I think at the end of the day, we do not want to decapitate the clinician, because you have to integrate what you measure with the clinical presentation. And if you will lose that, and if as an imager, of course, there's always the risk to just focus on the imaging, but we have to also acknowledge that, as you said, an athlete's heart, if I have a pregnant or a professional athlete, then I have to, of course, understand that how the heart looks like and works is just by default different. Yeah. And there's another one. It would be interesting if you had any lab data, such as proBNP, that could be combined with imaging and invasive parameters. So sort of what we already talked about.
No, absolutely. I mean, this was historic data in the UK. NT-proBNP came into the guidelines document a bit later. There was mixed bag of data, so we avoided it, to be honest. But 100% NT-proBNP. And again, when NT-proBNP came out as a imaging biomarker for the strain on the heart in heart failure, it is still a very promising tool with a very high sensitivity, but its specificity is very low. And we know this, and equally in HFpEF patients, some US studies have demonstrated that actually in obese females, the sensitivity of NT-proBNP to pick up HFpEF can be low. So you can't use NT-proBNP alone. You do need some level of imaging assessment or invasive assessment in those patient population.
Yeah. Okay. So we're running a bit out of time here, but I think it was well worth every minute. So I want to thank you so much. This was one of the best journal clubs, I think, ever. I'm very happy about the lively discussion, about the wonderful presentation, and also the critical comments, Davide. So it is important. So of course, you have to answer one last quick question very shortly. What's next?
There's lots going on. There's lots going on.
I can imagine.
We are trying to develop pressure models inside the whole heart.
Yeah.
We're looking at pressure volume loop relationships inside the heart. But I think we are trying to make the model simpler, not more complex, using 4-chamber cine. We are looking at also markers of flow. The question you would ask is where the flow, and you'll be surprised with the answer. We're looking at aortic flow and looking at flow eccentricity in the aorta in patients who don't have aortic valve disease, and building, because that all kind of informs the pressure after loading conditions. But I think also the role of tissue characterization, the role of 4D flow. I think you're talking about my career. It's going to be next 25 years.
Fantastic. And I'm sure you also will trigger a lot of important research that will help us all to understand. And I would just, if you look up a paper on waltz, there's assessed by MR, this fits into that you use a fairly simple, just a cine, and the information on the pressure and the peripheral arterial pressure to assess waltz. This may be but so in concluding, I want to say why I find this extremely interesting is not just because of its potential, but also that it would be integrated into a scan that also gives information on tissue and on flow if you want. So this more and more sounds like the comprehensive scan that we always dreamed of, and this one does not need contrast agents and uses standardizable methods with quantitative data. So congratulations again from my end. With that, I'll let everybody go. In April, we have a short pause because of the Easter holidays. So the next Journal Club will be in May, beginning of May. Stay tuned. And we also will have a new co-host. And as a pre-announcement, so Nicole Seiberlich will join me as a co-host of the CMR Journal Club. So she will take care of the more experimental papers. So Pankaj and Davide, thank you very much for joining, and also everybody else, and all the best for your important work.
Thank you.
Take care. Bye-bye.
Bye.